Thank you very much, Dr. Del Toro. Please come and join us, and we'll ask Pedro Rodriguez to come and join us on the stage as well. Are there any questions from the floor? So I will start with a question, if you don't mind. So, Dr. Del Toro, you have nicely explained that the mechanisms of resistance to FGFR2 inhibitor are related to new clonal evolution of new mutations. We have recently seen the data of the relay compound, which actually seems to be quite interesting with a response rate which is almost then double to the ones we have seen so far. Do you think that is related and only related to the fact that it's more specific and then we can increase the dose? Absolutely. Or also because we are acting on other mutations and in this way we prevent the emergence of those clones?
I mean, I can't say I don't know, but what I think is that we can get higher achievable concentrations by two mechanisms. One is increased receptor specificity, which we see, but then also mutant selectivity. I don't know about the mutant selectivity for that, but yes, if you have better receptor selectivity, you're going to get higher concentrations, you can tolerate higher doses, you can suppress more mutations.
And do you think that they will be translated in overall long-term control if you are inhibiting all these mutations up front, or a sequential treatment?
That's a great question. So,
would give a different.
I mean, this is kind of crazy, but I think it's going to be really difficult to get drugs that are perfectly receptor specific. And even if they are perfectly receptor specific, every single cell in your body has every single one of these. And can you actually get a high enough drug concentration even with perfect receptor specificity? I don't know. Maybe you can't. Maybe what you want to do is use a first-gen inhibitor to drive the emergence of mutations and then have a next-gen that is mutation selective so that it only hits the mutated ones. So you're kind of like driving the resistance in order to get a better target to attach to. So, I mean, I don't know, maybe you want receptor specificity, you focus on the wild type, or maybe you focus on mutant selectivity and let the first gen create your target for you. I don't know.
That's it.
I have a question for Dr. Crowley. You briefly touched on this at the end of your presentation about the BILCAP data. The percentage of alterations you showed are similar, but not exactly the percentages we are seeing in the advanced setting. So do you think the percentage of the different mutations or alterations can be different in the adjuvant setting and in the advanced first line, second line? Because if so, it's also important to define, to do new studies. For instance, we started thinking that FGFR gene fusions were observed in 20% of the patients. Now it's probably 9, but in your data is 20. So it's related to the small number of patients analyzed, or maybe a different setting?
I think it's sort of a little column A and a little column B in this one. I mean, this, like I said, is only 45 of the, we're never going to get all 447 just because of technical issues, but potentially several hundred that we'll get from the BILCAP study. And you're right, these are definitely very much surgical resected adjuvant patients. We do, or we will, ask me again in a couple of months, we'll have access to a similar data set of metastatic cancer patients, and we are going to do a direct comparison between the two, sort of using the same mechanisms of analysis to see if there is a difference between a directed comparison between the patients in the adjuvant setting and metastatic. So we are going to do that comparison. We just haven't gotten through the data yet.
Johan?
Thank you. This question is for Daniel. You're talking about the selectivity of the FGFR2 inhibitors, but much has also been made about the binding, the ATP binding versus covalent binding. What are your thoughts about that going forward?
How do I answer that appropriately? So I think receptor dwell time is important. I don't think you necessarily need covalent interaction to get that. I also don't know how much of a liability mutations at the C492 covalent site are actually going to be. It's possible that that's not really that big of a deal. If that's the case, well, I think being able to tackle the N550 and the V565 mutations is much more important than whether you're covalent or reversible. I think that should be the focus. I think both covalent and reversible have promise. I don't think that one is necessarily better than the other. I think that the main mutations that we showed here are going to be problems for both of them, and that's what we need to focus on.
And the follow-up question on that, we know that the co-occurrence of other molecular alterations with the FGFR2 fusion can change the response to at least pemigatinib. You have shown that there are some patients who develop more mutations even in the same site. Have you noticed if this is associated with the co-occurrence of other molecular alterations? I mean, colorectal cancer, we have learned that mutation in KRAS G12C might be changed by other, EGFR pathway and loop.
We've looked, and it's not obvious. If anyone knows how to do like agnostic Bayesian analyses of large data sets and wants to do that for me, then maybe we could get an answer, but he certainly can't find it by looking at 1, 2, or 3 things at a time.
Okay, thank you. And Valerie, last year we presented the case of a patient with an HER2 amplification that unfortunately, in our experience, did not respond very well to HER2 targeting therapy because she had an amplification in a EGFR. And I was really curious to see if that is an isolated case or if it's a finding that you find in your extended cohort.
Oh, the extended cohort, we are starting to find a lot of EGFR amplified patients as well. So just judging by the numbers, we are finding patients with more than one amplification at a time. I wouldn't be surprised if there wasn't again, the total number isn't huge, but there are a significant number of patients who do have co-amplified genes like that. And obviously that's going to affect whether or not they'll respond to drugs that target simply one of those amplifications. And, that might, see what happened to your patient.
Yeah. And for your other MET amplification, I know that it's associated with a different prognosis in your case.
Yeah.
Have you seen if there is an enrichment in distal cholangiocarcinoma or periareal cholangiocarcinoma that can drive this prognostic effect?
All I had at that point, they were all intrahepatic cholangiocarcinoma. The new data set I've got is still sort of half intrahepatic, half gallbladder, and a couple of perihyalin distal. The data is sort of every month or so I'm getting more and more data coming through. So as the data set gets bigger, we'll have more of an indication of the different subtypes.
And Pedro, I was curious to see in your, your registry is going, is going worldwide. So do you have any data or do you plan to study any effect of deprivation on the incidence and management of cholangiocarcinoma worldwide? So now that you have access to data from different countries in the world, do you think you are a better place to study this?
Well, for the incidence part, I think it will be difficult because this is a prospective study. It's not an epidemiological one. So I think getting actual robust data on the incidence, it will be difficult. It will be, actually we are doing that in the Basque Country, in Spain, where we started the registry. So we have all the cases that were diagnosed between 2010 and 2019. So in that case, we can have an idea of the incidence in the Basque Country, but the registry now is not an epidemiological study, so it's not aiming to have an incidence study. It would be great, but I think we have a lot of limitations in that sense.